background on my experience. I actually have worked previously in Indonesia, although it was many years ago. It was 1988 and 89, so I'm showing my age here. You can see all the gray hairs. So I worked in the Department Kesehatan in Jakarta with Pustek Nakas on Center for Pre-Service Training for Non-Physician staff, working with schools and academies around Indonesia, around Java, also in Sulawesi Selatan and other parts of Indonesia as well. So I have some familiarity with Indonesia, although I realize that a lot has changed since 1989. Is that right? I think a lot's changed. Saya tahu bahasa Indonesia sedikit-sedikit saja. So I have to speak bahasa Inggris. The words are coming back quickly, though, so I hope I'll be able to get all the rust out of my head here. What I want to talk about today is our programs on healthcare quality improvement and quality measurement at RTI. Areas we've been working on, and one particular topic I think may be of interest to Indonesia with your new national health insurance program that's starting next year. As you pull together the health insurance programs together into one national program. It's a big job, and I know that a lot of people are working hard on it. We were just at a conference in Semarang the last several days talking about health informatics for the new national health insurance program, and I think it sounds like a lot of progress, but a lot of development yet to come. And so I'm hoping that this will provide some background on areas that may be of interest and may be of use as well as you consider the development of your program. So my area is healthcare quality and outcomes. That's my department at RTI. We work on 4 different areas, basically. One is evidence-based analysis of clinical guidelines. So how do we define what is the right guideline to use? Bring together experts, say, on hypertension, to discuss when should patients with hypertension start receiving drugs, and when should you try and treat just with diet and exercise. So what's the right, so we work with physicians and epidemiologists and experts on that area of clinical guidelines, and then take the guidelines and develop measurements of quality. So how do we decide who has hypertension and what drugs are applicable? What's the way of measuring hypertension? Is it through medical records or health insurance claims or other ways? Then we also work on systems to routinely collect data on healthcare quality, say from hospitals, public health agencies, clinics, and others. And finally, to evaluate, our 4th area is evaluating programs to improve quality. So if you hire a special nurse to educate diabetes patients, right, on how to take care of their diabetes themselves between visits to the doctor, are those effective or not? Does the quality measurement data show that that's been effective? So we work in those areas, and today I'm going to talk about one particular issue focusing more on quality measurement. Let's see. Oh, thank you. Okay, so this is forward. Is that right? Oop, which one's forward? Okay, great. Okay, thank you. Thank you very much. So my presentation outline today will include quality measurement, examples of using health insurance claims data as you begin to expand your health insurance claims systems with the new National Health Insurance Scheme. We saw that there's going to be an effort for using some of the, say, DRG methods that are currently being used by ASKAS, expanding them to all the different types of health insurance in Indonesia, and then looking at expanding ways of paying other providers as well, not just hospitals. So what I want to talk about is, as the BPJS system is developed next year and on, I think it will take a number of years, of course, to implement. They were talking about by 2019, maybe? Developing fully. So as that's being developed, we're going to think about what are the systems that are needed for developing the health insurance program effectively. And so expanding access, let's see here. All right. That's it. Okay. So expanding access to health care is, of course, an important goal. You want universal health coverage, right? It's a very positive goal for the country. Expanding access to care for people of all different income levels and regions. I know it's a challenge in some of the, especially some of the rural areas, small islands. Indonesia has so many islands, very difficult to reach them all. But at the same time, a parallel goal is to make sure that the services are of good quality. So expanding access is important, but we need to make sure that the services people receive are also of good quality, so it really improves their care and improves the outcomes for the country. So you have healthy population. So the health insurance claims data are the data sent by health insurance organizations, such include hospitals, clinics, private physicians, private laboratories, and other providers as they're brought into the health insurance program. And one of the things that is important to think about with this data is that the data quality is high because everybody wants to be paid, right? So if you want to be paid and you have to send data to BPJS to get the payment, then BPJS can say, here's the data you must send us. And so that's a way to get good quality data. Because sometimes data are not of good quality if it's not linked to payment. So what we want to do is make sure that when providers submit the data to get paid, that we can think about what data do we want to ask them to submit. So the idea is to use the data quality from the claims data for other purposes. So we have data. So the basic idea of the data is to get paid. So make sure that the hospitals get paid, make sure the doctors get paid through BPJS. But also we can now say, well, let's take advantage of that system and say, let's also use it for improving quality. Because we have a system being established, we can use it for two purposes, not just one. So the key issue will be to work with the health insurance organizations. Let's see. Here we are. Okay. The purpose will be to work with the health insurance organizations to ensure that the types of data they require will also be useful for the quality assurance. So we can think about other sources of data for quality of care, many of which you may be familiar with. So we can have administrative records for the qualifications of doctors and nurses. So when they get paid, have they received a good medical training? Are the hospitals, are they licensed or accredited? That's one way of looking at quality. This is intended to look at another way. You can also look at household surveys. Say if you want to see if children are all immunized, that's a common way of measuring whether children have been immunized, of course, through household surveys, and then registries on immunizations and medical records as well. But what we want to do is make sure that the data are of high quality. So again, data that are not linked to payment of services sometimes are of low quality. So how can we make sure, again, that the data are high quality? And this is an example we heard from Thailand at the FK conference in Semarang just a couple of days ago. They were saying this is one of the things that they've been working on, is getting more quality information through the healthcare claims, because they found that that's a good way to collect data and make sure that the hospitals and doctors provide the good data. So you have the opportunity here with BPJS to consider ways to use the claims data to improve the quality. So next topic I want to talk about is different types of quality measures. And when we're thinking about what data are useful to collect from hospitals and doctors, what types of data do you want to collect? So we've got three types here: structure or inputs, process, and outcomes. The first type, structure, here we're thinking of things like, what are the inputs into healthcare? What types of information do we want to know? Again, qualified physicians, licensed hospitals, licensed health centers, well-maintained medical equipment, and make sure it's well-maintained. Do you have information technology? Do you have sufficient pharmaceuticals? So this is one basic measure of quality. It's a beginning. So if you go to a licensed hospital, you're at a good quality hospital in general. It doesn't guarantee that the service you receive will be high quality, but it's, at least you know you're at a good quality hospital. Next is the process measures. So we think about this is the procedures used to diagnose a patient, prescribe testing or treatment. So again, when do we start giving drugs to people with hypertension? What types of drugs do we give to people to prevent strokes? We saw that stroke is a very common cause of death here in Indonesia, an area that might be an area of focus, and hypertension as well. We think about, do we have underuse of treatment, like are the drugs going to the right patients? Or are some of them not getting it? Misuse? Are the right drugs getting to the patient? So if you have a cough and cold, do you get antibiotics? Is that a good idea? Huh? Yes? No? No, because we know antibiotics don't treat viruses, right? So that's a waste of money. We don't have much money. We don't want to waste the antibiotics on things where it won't help. So, and then overuse is another issue. So overuse is one where we think about hospitals or hospital emergency rooms. You ever see one that's really crowded? And there's too many patients and not everybody can get seen very quickly and the doctors are all rushed and they're only seeing the patients for a few minutes. So that's overuse. Not everybody maybe needs to be there. So that's another measure we'll be looking at. So our ultimate goal is for outcomes. So outcomes are reducing morbidity and mortality. So those are the things we want to get to eventually. It's harder to measure directly, but those are the things we'll want to get to eventually. Okay, so examples of quality measures that are possible from health insurance claims data. So I'm going to give you some examples here, not suggesting that all of these are right for Indonesia, but here's some examples of things that have been used in other countries that you may want to think about as possible approaches for Indonesia. So we've got many different topics here. So this gives you an idea that claims data can be used in many ways to collect data for quality. So hospital admissions, this is, again, the problem of overuse. Sometimes patients should be cared for on outpatient basis more. They don't need to necessarily go into the hospital. Some types of pneumonia, diabetes. Maybe it's possible to prevent hospital admissions and also readmissions. If the patient is discharged from the hospital, we don't want them to come back right away, right? We want them to be able to stay home, make sure they were cared for well at the hospital. If they come back within 30 days, it may mean that the hospital care was not very good. Yeah, not always, but it's one way of measuring. So this is a type of measure, a simple measure you can use to look at quality of hospital care. How many patients came back within 30 days? And that information would then be in the claims data because they would be the hospital would be submitting to BPJS for more reimbursement on the DRG system when the patient came back. And as long as you measure the dates of the patient was there, you can use the computer to analyze whether they came back within 30 days. Okay, next is emergency department visits. Same thing. Some patients may use the emergency department too much, right? They come back very often and they make it very crowded. So we want to check on which patients are using it a lot. Patient safety, you may have hospital-acquired infections, right, sometimes. If you have pulmonary embolism, venous thromboembolisms in the hospital, it's a common problem of hospital patient safety issue. How can you prevent that? Decubitus ulcers, also allergic reactions to drugs. Can we prevent that? Can we check on the patient's allergies to drugs to make sure they don't have allergic reactions while they're in the hospital to the drugs they're given? In stroke, so to the stroke patients, again, I saw that this is one of the highest causes of death here in Indonesia. How can we make sure we get the right drugs to the patients? Do they get the drug therapy? Are they on, say, warfarin for atrial fibrillation to help prevent strokes? Do we get that to them in a timely manner? Okay, diabetes. This is one we work on a lot in the United States. We're having a big problem with expansion of diabetes. I'm also working on this in the country of Brunei, here not too far away, on the island of Borneo. So the issue is, you've got how often do you want to test for glycosylated hemoglobin? And what are the results? The results, were they below 9%, which means you have good control of diabetes, or are they above 9%, which means you have a problem? The patient is not blood sugar is not under good control, and it may cause complications like kidney failure, cause neuropathy. You have amputations of the legs, or you have retinopathy, so it can cause a lot of problems. And then cholesterol testing. How often do you get tested for the patients, and what are the results? And eye exams, foot exams. So many different ways of measuring what's the quality of diabetes care. Hypertension, I know another issue here in Indonesia. I think we saw that maybe 31% of the population has hypertension in Indonesia overall. So how often are we getting checked? And what are the results? How can we keep track of that data? Coronary artery disease. Do we have drug therapy for lowering LDL cholesterol? When do we start that? Is that possible? What's appropriate? What are the clinical guidelines you may have here in Indonesia that we need to track information on? And other results of cholesterol testing. Can we get it below 130 for patients? So preventive care, then we have different vaccines. We have flu vaccines, pneumonia, cancer screening, so mammograms for women. How often do we have them? This is some examples of measures that are used in the US and other countries. Cervical cancer screening, and then colorectal cancer screening, and of course childhood immunizations are a big priority in many countries. Then regional quality of care indicators. So how many hospital admissions do you have, and how many readmissions do you have in different provinces, Kabupaten and Kota here in Indonesia? Which cities are doing better on readmissions and why? And then you could have some discussion and comparison, say using web-based discussion groups like Linda was talking about. Why are some cities able to do a better job than others, and can you learn from the other cities on what's ways to improve your quality? And you can compare also, say, the disease-specific measures I was talking about with diabetes, hypertension, stroke. Compare those across different regions, different kabupaten, different provinces. Where are the areas that are doing a better job, and how can we spread the word, spread the methods they're using? Okay, so we talked about some of the quality measures that are possible. Then how do we get the data? The measures sound good, but we got to get the data, and it's sometimes hard to get good quality data. So here's some examples of the types of information that can come from a health insurance system, and that BPJS could be developing over a number of years. It's not going to happen right away, of course, because it takes a while to develop these systems. But the advantage is, again, because Indonesia's made the commitment to national health insurance, the systems will be built. We need to just make sure that the data collected are useful for quality measurement and not only for payment to hospitals or doctors. That's the idea. So for the beneficiaries or the patients, we want the basic information on their ID number so you can track which patients. If the patient comes back, the readmission to the hospital, you know it was the same person. I know there's been some discussion of a national ID card in Indonesia. This is one thing that they did in Thailand to make it easier to track who was receiving services and who was, say, coming back to the hospital. Then measure where people live, so you can make the comparisons. Date of birth, so that for some quality measures you need to know if people are over age 50 or under age 6. Gender, some are specific for women, say for cancer screening. And you need to know, when people have died. So, when do you take them out of the measurement system? Okay, so then doctors, you need to know, say, doctor ID number. That'll be for insurance billing also. Know the medical specialties, so you can look at the different, say, types of doctors treating different patients. Keeping track of hospitals as well, so we can see which hospitals have higher rates of admissions, higher rates of readmissions, and keep track of that basic information. And this should all be in the health insurance system because for payment to the hospitals and doctors, this will be basic information. Similar for health centers and laboratories, maybe their independent laboratories develop pharmacies, so we can track the different types of drugs being provided to patients, again, for, say, drugs for hypertension, drugs for cholesterol, drugs for stroke prevention. Then the hospital, this is the area that may develop the claims data first, because the hospitals have better management system, more resources, more budget for collecting data. So you can look at the hospital ID number. The date of admission and discharge are very important, so you can tell if patients have been readmitted within 30 days, or was it 6 months. Diagnosis codes, International Classification of Diseases. This is the standard from WHO that we understand that Indonesia will be working with to help develop the hospital reimbursement system based on DRGs. And then this can also help you identify who has diseases, like who has diabetes, who has hypertension, who has the strokes. So you know which patient have the diseases for those quality measures that are based on individual diseases. Then you know who got particular kinds of surgeries, again the DRGs for reimbursement, but also help you know what patients have then pharmaceuticals. So did the patient get drugs for preventing stroke and preventing venous thromboembolism when they come into the hospital? What types of laboratory tests did they get? And what was their discharge status? Then hospital outpatient claims data. Again, we can look at diagnosis codes to find out who's got diabetes, who's got hypertension, who's got stroke, what types of visits do they have, and then was it an emergency department visit? Again, we want to make sure that people aren't overusing the emergency department instead of regular primary health care facilities. So it's a way of measuring the information on emergency department visits. Similar for health centers or say puskesmas or private clinics, what kind of diagnosis codes can you track for people's diseases? Physician claims data, again, if people see as the physicians themselves start billing the health insurance, you can look at diagnosis codes, understand what patients have particular diseases, and then how the follow-up is happening from other information. Laboratory claims data, so if you have a laboratory test, say for glycosylated hemoglobin for diabetes or for LDL cholesterol, are we tracking those results, and how the results looking for individual patients, and who's getting then the treatment that's needed? Find radiology procedures, and then pharmacy claims data. Again, many of these quality measures are based on people getting the right drugs when they're needed to help prevent diseases or treat diseases. So that kind of information can also be included when the pharmacies are being paid by the health insurance. Okay, so a few conclusions. We've got quality measurement that can have large benefits by helping prove that access to care also improves patient care. So again, as I said at the beginning, access to care is really important, and universal health coverage is a wonderful goal, but need to make sure that the access to care also provides access to high quality care, and that the care really helps people improve their health. But quality measurement also can have costs. Just collecting data is costly sometimes. So here we're saying, instead of collecting data for quality separately, let's take advantage of the fact that you're now developing this national health insurance program and collect quality data along with the payment data that are being used to pay the hospitals and doctors and other clinics. So it's a way to reduce the cost of quality measurement and improve quality data. I've provided some examples here. This is mainly, I think, to stimulate your thinking about what your Ministry of Health and your health insurance program want to think about the benefits for Indonesia of different types of measures. You know, which ones would be most beneficial here, thinking about the types of diseases you're faced with, and the types of health topics. So again, thinking about stroke and hypertension, I know are areas of particular concern here in Indonesia. That may be an area you want to focus on. We know that certain provinces or cities are going to get the health insurance claims data probably earlier. So the systems will be developed probably earlier here in Yogyakarta and Jakarta, big cities, as opposed to some of the more rural provinces, but Irian Jaya, Ambon, and others that are not as well developed in terms of their facilities or their data systems. Let's see. So again, some other strategies. Think about also which healthcare services are going to be covered by BPJS initially, and then think about focusing the quality measurement on those services, because that'll be a way of reducing the cost of the data collection as well. And then, of course, phase in over time and plan for multi-year implementation. That the cost is high initially, so thinking about starting with a few basic measures that are of the highest priority, like stroke or hypertension, then moving to others later, or say hospital readmissions, emergency room visits if there's too many. So finally, here's my contact information. I'd be glad to, of course, to follow up with you and take questions now as well.